it's Olivia. Welcome back to our endocrinology chapter. In this section, we'll be talking about hyperosmolar hyperglycemic state. In our last video, we talked about DKA, which is associated with type 1 diabetes. So in this video, we'll be going over HHS, which is more associated with type 2 diabetes. And the pathophysiology centers around osmotic diuresis and dehydration. So what's happening here is you have decreased insulin sensitivity or insulin insensitivity. That is going to lead to unregulated hyperglycemia, which will in turn cause osmotic diuresis, dehydration, and that is what leads to the pathology here of HHS. Looking down at your diagram, remember when we talked about all the different pathways that can lead to pathology in diabetes, the pathway here that is causing most of the physiology and the symptoms of HHS is going to be this pathway down here that is caused from hyperglycemia leading to polyuria through the osmotic diuresis, loss of sodium and water, which will be leading to dehydration and hypovolemia. This is probably the crux of HHS, this dehydration that is going to lead to potentially circulation failure and also coma and even death if left untreated. That is the most severe outcome of HHS and why this is a dangerous pathology. And it's also important to remember that this increased plasma osmolarity associated with HHS is also going to lead to increased thirst. So even though you have increased urination, you also have increased thirst. You're just unable to keep up with these losses, and that is why overall you're going to end up in a state of dehydration. And then one key part of HHS that is going to separate it from DKA and type 1 diabetes is that in HHS you still have insulin present. So remember, in DKA we didn't have any insulin present and we had high levels of glucagon, and this is what stimulated our lipolysis, our ketogenesis, processes like that responsible for making more glucose. But in HHS we actually do still have insulin present. It just isn't able to exert its end effects at end target organs because these organs have become desensitized to the presence of insulin. But because insulin is still present in the cell, this is going to prevent the stimulation of ketogenesis. So you're not going to see very high levels of ketogenesis in HHS, which also means that you will not see a metabolic gap acidosis. While patients with HHS may have an acidosis, certainly due to this elevation in serum lactate that can arise from decreased tissue perfusion, this lactic acidosis will not rise to the level of an anion gap metabolic acidosis, and it's really important for you to remember that in HHS, usually the anion gap is normal, whereas in DKA, that anion gap should be severely elevated. A great way to distinguish between these two pathologies on a step 1 question. Now the presentation for HHS, it's usually going to be in patients with type 2 diabetes, as we mentioned above. These patients are often elderly patients who can't drink, so they're unable to keep up very well with these loss of water, this polyuria that's happening. And because they can't drink, then they're very susceptible to the dehydration that occurs with HHS. HHS, just like DKA in type 1 diabetes patients, can be precipitated by pretty much any shock to the system, so infection, lack of medication, heart attack, stroke, or pancreatitis, anything that's going to put a stress on the system of a patient with type 2 diabetes can put them at risk for HHS. And the symptoms, as we've already alluded to in our discussion of the pathophysiology, are going to be thirst, polyuria, so you're urinating a lot, leading to this dehydration. That dehydration is then what is going to cause the circulation failure, which will lead to some of our symptoms like lethargy, seizure, coma, and even death. And then our diagnostics here are going to be really important to help us distinguish HHS from DKA and type 1 diabetes. So first, you're going to have an elevated glucose, often above 600 milligrams per deciliter. And usually in DKA, usually when they're asking you about this on step 1, they will give you a serum glucose less than 600, but still elevated. If they give you a blood glucose that is over 600, that is more indicative of HHS. This isn't a perfect system, but this is certainly a good clue to look for. And then additionally, increased serum osmolality greater than 320 milliosmol. So in DKA, certainly you can have an increased serum osmolality because of all that glucose floating around. But as we just discussed, in DKA, even though you may have an increase in serum osmolality, this increase in serum osmolality will likely not exceed 320 milliosmols, whereas in HHS, it is likely to exceed 320 milliosmols, and that lab value is strongly indicative of HHS over DKA. Additionally, some negative findings that might help you clarify whether this is HHS or DKA in a board style question. In HHS, you're not going to see any ketones. So there'll be no ketones in the urine, there'll be no ketones in the breath, you won't have that fruity odor, and no ketones in the blood if you were to test that. And then additionally, it's important to remember that you will not have an anion gap metabolic acidosis in HHS. So your bicarb should be at least either in the normal range or at the very least above 18. And if you calculated this out with your anion gap equation, sodium minus bicarb minus the chloride, that number should be less than 12 because you will not see an anion gap in HHS, and that is probably one of the biggest distinguishing factors between the two, between HHS and DKA. Moving on to management, the management of DKA, because this is primarily a dehydration problem, is first and foremost fluids. So give your patient normal saline, make sure you start them on fluids, and then again, we are going to need to replete their electrolytes. They could be losing sodium and potassium, other electrolytes along with water, so it's important to replete those as well. Certainly make sure that you replete the potassium before you start them on IV insulin, as insulin causes potassium to shift into and could cause a dangerous hypokalemia leading to arrhythmia if you're not careful. So fluids, electrolytes, and then insulin to treat HHS. Now I know that was a lot of information. Let's quickly recap what we talked about in this video. So HHS is seen in type 2 diabetes, whereas DKA is seen in type 1 diabetes. The primary pathophysiology is severe dehydration, which is going to lead to our symptoms of thirst, polyuria, coma, seizure, and even death. You can differentiate HHS from DKA because the serum osmolality is going to be substantially increased. Again, you may have an increased serum osmolality in DKA as well, but it will be more markedly increased and above this 320 mark in HHS. Your anion gap in HHS is most likely going to be normal, which is a great distinguishing factor from DKA. And then there will not be any ketones in your urine or in your blood. So if you see those, think DKA, not HHS. Finally, the management is with fluids, then electrolytes, and then insulin. And how would they ask you about this on a board style question? Well, something they might ask is an 83-year-old man is brought to the emergency department from his long-term care facility for polyuria, lethargy, and altered mental status for the past 3 days. He has a known history of diabetes for which he takes insulin. Labs reveal a glucose of 650 and a bicarb of 24. What is the most likely underlying cause of this patient's condition? Well, this is an elderly patient in a long-term care facility that has diabetes, but they don't tell us if this is type 1 or type 2 diabetes. However, looking at their presentation where they have altered mental status, polyuria, lethargy, certainly DKA and HHS are somewhere on my differential. Looking further into his labs, we see that this patient has a glucose of 650, certainly above our cutoff for HHS over DKA, making me a little bit more suspicious for HHS. And then additionally, they have a normal bicarb. So this bicarb of 24, which is on the lower end of normal, admittedly, but still within the normal range, that in my mind basically rules out DKA because this is not an acidosis if we don't have a bicarb that is below the normal range. This patient is not yet acidotic, so I have a higher suspicion for HHS here given this normal bicarb, and certainly that fits with the presentation of an elderly patient who is in a long-term care facility, may not be able to take care of all of his own needs, and maybe can't drink or hasn't been drinking as much water as he should, exacerbating his risk for HHS. And that's all I have for you on hyperosmolar hyperglycemic state. I hope this video was helpful, and I'll see you next time.